So let me introduce Dr. Adam, and thank you for giving your time to us tonight. We're really grateful that you're here. He's a doctor twice, because he's a what I call a FUD. He's a PhD. He's also a proper. Well, I'm not sure whether, isn't it, if you're a PhD, you're meant to be a proper doctor, whereas if you're a doctor,
that's what they say.
You're a real doctor if you're a PhD, but you're a sort of just a doctor if you're a medical doctor. But you're everything. You're both. I'm very grateful to you coming tonight to talk to us about the BRCA gene mutation. I have a friend at the moment who is in the last stages of her life, and sadly she has the BRCA gene. Her mother had it, and I remember when, oh my gosh, over 50 years ago, her mother died aged 40, having got breast cancer at 36, died at 40, and it has affected my friend, her sister, her aunt, their entire family. So it's something that we really do need to be aware of and know what we can do about it if, God forbid, we or a member of our family have it. Dr. Rosenthal is a consultant gynaecologist at UCLH, which is University College London Hospital. He's clinical lead on familial ovarian cancer, a screening study. He's medical advisor to a number of charities, including the Eve Appeal and Overcome, that's spelt OVA, unsurprisingly. He's an absolute expert, obviously, from all the things that he clearly does. He's published widely, and he often speaks on TV and radio about the topic that he's very kindly agreed to talk to us about. So, everybody mute, please. I'm going to let you do it yourselves. I'm going to mute. Adam, Dr. Adam, over to you.
Thank you very much for the very kind introduction. Can I ask you, can you just allow me to share my screen? When I hit the button, it says the host has disabled the screen sharing. Because it would be nice if you can see the slides. I think you're on mute at the moment, actually. I'll try now.
Yeah, try now.
Well done. That's done it. Thank you. Okay, so can you now see my screen? Yeah, I can see some thumbs up. That's a good start. Okay, so let's make it nice and big. So we're going to talk about genes, mutations, and cancer. BRCA is what many of you, I'm sure, are more familiar with than the other genes, but I do want to take the opportunity to mention some other genes because I don't want everyone to think in silos and miss an opportunity to realize that maybe there's something going on in their family. And obviously with a largely Jewish audience, you will be more familiar with BRCA because sadly BRCA is more common amongst people of Ashkenazi Jewish heritage, and it predominantly causes breast and ovarian cancer. And some of you, we've already heard, have sadly got friends or relatives who have already had the situation themselves. But BRCA is not the only, or two genes that are responsible for inherited cancer syndromes. And I think it's important to mention the others briefly so that you're aware of them. And so you can spread the message and get people with a strong family history of, for example, bowel cancer to do something about that as well. Although I'm a gynecologist and I really deal only with gynecological surgery, some of the patients I see do have a risky gene that results in them being at risk of not just gynecological cancers, but other kinds of cancers as well. And it's vital for me as a healthcare professional to know that, but I think it's really also important for the public to be aware and to go to their GP when they realise they've got a strong family history of cancer. So I'm going to give you some clues about that as well. So this is an example of a family tree of a typical family that I might see in my clinic. And for those of you that aren't familiar with family trees, circles are women and squares are men. And rather brutally, the diagonal line through one of those circles or squares means that that person is no longer with us. The numbers are the ages and the letters are the kind of cancer. So the question mark is the patient I'm seeing in front of me, and she's got two sisters. One of them had breast cancer at the age of 44 on her right, and the other had ovarian cancer at the age of 56. and those siblings are both alive. Their mother had ovarian cancer at the age of 42, from which she sadly died. And on the grandparents of the mother, you can see that there's a man there who had P, which is prostate cancer, and that was at a pretty young age. 52 is much younger than average to get prostate cancer. And their mother also had a sister who has breast cancer at the age of 46. There happens to be a breast cancer on the other side of the family in the paternal grandmother. That's the father's grandmother, the father's mother rather. And she had breast cancer, but that was at the age of 62, which is a much more sort of standard age for getting breast cancer in the general public. So when I see a family tree like this, I immediately think there's definitely something of note going on here. And knowing what I do about the area, knowing that there are some ovarian cancers here clustering with breast cancer, they're all at really pretty young ages. And there's a young male with prostate cancer as well, at a young age for prostate cancer. This immediately makes me think that this family contains an inherited genetic predisposition to cancer, and that predisposition is most likely to be a BRCA2 or BRCA2 gene mutation, because that can cause breast and ovarian cancer and also prostate cancer in men. It increases the risk. So this is the sort of scenario I'm having to take into account when I see the patient who is the question mark on the diagram. So I hope that makes some reasonable sense to you. Now, the whole world woke up to the subject of inherited cancer predisposition thanks to Angelina Jolie, the American actress, who you're all, I'm sure, very familiar with. And she actually has done a huge amount of good in raising public awareness of inherited cancer. Jolie herself has a BRCA gene mutation, and she has had her ovaries removed, and she's also had her breasts removed, and she wrote about it, I think it was in the New York Times, and then Time did this big article about it. And it's a pretty brave thing for a celebrity to put their health issues in the public domain and to talk about what is, you know, these are life-changing operations that she and sadly many other women, I didn't look after Angelina, but I look after many women like her. And their decision-making about what they decide to do about their risk of cancer is not easy, and it's very personal and very individual. And I'm sure Hayley will give you a feel for that later. So Angelina has actually done a lot of good by raising public awareness, and we noticed it in our clinics, and the rates of referral to inherited cancer clinics went up massively in the wake of her making her story public to really the whole world. So why is this such an important area of medicine? Well, it's really because we can do quite a lot to help. The first thing is to try and prevent the cancer in the first place. And there are two ways of doing that, really. In terms of breast cancer, which I don't know much about, so please don't ask me detailed questions later. Chemoprevention means taking a drug to try to reduce the risk of getting, in this case, breast cancer. And that would be a drug called tamoxifen, which is used to treat breast cancer, can also be taken to prevent it. For people at high risk of bowel cancer, they can actually take aspirin under medical supervision also, and this can also dramatically cut their risk of inherited bowel cancer. What I deal with mainly is risk-reducing surgery. We call it risk-reducing because you can never take away the risk completely, but in certain situations you get pretty close to complete protection. And this is surgery to prevent cancer. You are literally removing the organ in the body which is at risk of developing cancer. Screening doesn't, in these particular scenarios, tend to prevent cancer. We know that cervical screening prevents cancer. Cervical cancer is not an inherited condition. It's due to a virus, which is why we now vaccinate young boys and girls against it. But screening with cervical cancer will detect precancerous conditions which you can treat and then prevent the patient from ever getting the cancer in the first place. Sadly, that's not really the case with people with inherited cancers, at least as far as ovarian and breast are concerned. What we're doing with screening is to try to detect them earlier in the hope that we might be able to cure them. Now, with breast cancer, you can increase the cure rate with screening. Unfortunately, with ovarian cancer at the moment, that's not the case. I can talk about ovarian cancer screening later if people want me to, but it's not yet in routine practice for BRCA carriers, although I'm working to try and get that available on the NHS whilst women are making up their mind about having the surgery. It's not something they can safely do in the long term. It's really just a temporary damage limitation strategy until they've made that difficult decision to go ahead and have their tubes and ovaries removed. Nowadays, there's also the possibility of knowing you can give different drugs which can improve the outcome in cancer if you know someone is a BRCA carrier, because there are specific drugs that have been designed to work on tumours where their BRCA is not functioning. And that is more likely to be the case in the tumour, as you might expect, of someone who's already born with a BRCA mutation. Their tumours are more likely to have what's known as a double BRCA mutation and then be more susceptible to these specific drugs that have been designed to work on them. And these drugs are game changers. They are really making a difference to ovarian and breast cancer survival in women who are known to have mutations. The other really key benefit, I think, which is hugely beneficial and I think would make, I presume would make someone who had the bad news that they found out they were a carrier at least feel that there was a small silver lining for the family as a whole, is that once you know one member of a family has a mutation, it's then possible for them to undergo testing on the NHS to see if every other member of the family that wants to be tested, to see whether they've inherited the same predisposition or not. And if they have, then we've got all of these different opportunities to intervene and help them. And finally, a somewhat controversial topic, which is not my area of expertise, is that a pre-implantation genetic diagnosis. This is where a family that knows they have a mutation, and this doesn't have to be a cancer-causing mutation. There are many what are known as single gene defects, which are diseases caused by a mutation in a single gene which can be inherited and detected. You can often detect these problems in an embryo. And therefore, what you can do is where you've got a family which has some kind of devastating genetic condition, and it is a moot point ethically, I think, whether BRCA is a devastating condition to all people. But there are other non-cancer causing genetic predispositions which are devastating, causing horrendous childhood illnesses and developmental problems. And when it's established that these kinds of medical issues are due to a single gene defect, and where the technology is available and where the funding is available, it is possible to offer people who are known to carry one of these problems effectively a special kind of IVF, in vitro fertilization, where you can select out the embryos that do not contain this particular mutation, and you can use only those embryos to try and get the woman pregnant. And that way she can be sure that she's going to have a baby that doesn't carry the same devastating condition that has occurred in the family. Now, this has been done and can be done in patients with BRCA mutations and with Lynch syndrome and various other conditions which I'm going to briefly mention. But I don't get involved in that side of things myself, and it might be something you might want to discuss amongst yourselves at some point, the ethics of doing this. I'm neither for it nor against it. My job is to provide information to let people make up their mind about what they want to do. So why do these gene mutations cause cancer? Well, let's do a little bit of sort of basic terminology first of all. So syndrome means a group of symptoms which consistently occur together. And in this case, we're talking about a group of different kinds of cancer which typically cluster together in the same family. And when they do so, that means it's much more likely there's a specific gene mutation that's causing that pattern of cancers in that family. Genetic, of course, means to do with our genes, and genes, to look at it very simply, are the software or the programming instructions telling our cells how to work. Those instructions are spelled out in our DNA code, and mutations are simply a spelling mistake in the code. It really is as simple as that. We've all got mistakes in our code, and most of it we're born with, but then as we get older, we acquire more and more mutations. And most of these are completely harmless, and we don't suffer any ill effects from them whatsoever. But as time goes on and we acquire more and more of these mutations, just by chance, some of these mutations will damage critically important proteins in the cell and stop the cells functioning normally. And for example, if you've got a protein that normally stops a cell dividing uncontrollably, and that protein is no longer working because the DNA which coded for that protein is now mutated, then that protein doesn't do its job and the cell will carry on dividing incessantly. And that's one of the features of cancer. Now, it's also important to mention in terms of inherited syndromes that we've each got 2 copies of each gene in our body, bar those that are involved in sex determination. And we get 1 copy from our mum and 1 copy from our dad. And the great misconception amongst the public, and sadly amongst some healthcare professionals, is that genes like BRCA are only passed down through the maternal side of the family because they cause cancers that predominantly affect women. This is not the case. Men pass this gene or these genes on just as easily as women do. And in fact, men are more susceptible to certain kinds of cancer, such as prostate cancer, if they have, for example, a BRCA2 gene mutation. So don't fall into the trap of assuming because the women in your family get breast and ovarian cancer that it has to have been transmitted to them through their mother's side of the family. That is not the case. It could have come from the father's side. Now, inherited mutations in general probably account for about 1 in 10 cancers overall. It varies cancer by cancer, but ovarian is probably the cancer which is most likely to be due to an inherited mutation, and it's about 1 in 10. But it's important to also understand that just because you've got the mutation, it doesn't inevitably mean you're going to get a cancer. And at worst, it probably gives you a ballpark figure of a 1 in 2 chance of getting ovarian cancer. With breast cancer, it's worse. It's perhaps up to 8 in 10 women could get a breast cancer. But it equally means if you're undergoing major surgery to remove the organs at risk, you're doing that in the knowledge that you might never have been destined to get that cancer, despite the fact you've got the mutation. And what, of course, we're working really hard as clinicians and scientists to do is to try and be able to tell patients, are they a patient that is going to get a cancer, or are they one of the lucky ones who, despite having a mutation, isn't actually going to be very likely to get the cancer and therefore doesn't need to have the surgery. At the moment, the risk is so high with BRCA that people go for the surgery even knowing they may not get the cancer. Not everyone goes for the surgery, of course, but many do go for it, even though they know it's not guaranteed they would get the cancer, because sadly, it's such a grim thing for them and possibly fatal if they get one of these cancers that could otherwise have been prevented. I've already mentioned that these syndromes tend to cause more than one particular type of cancer, but the other key thing is that they can cause cancer at much younger ages than they would be expected to happen in the general public. And that's because they're born with one of the 2 copies of the gene already not functioning. So as time goes by, they only need to knock out the other copy to start getting the problem that causes the cancer. Whereas if you weren't born with one of these copies already not working, then statistically it would take you longer through environmental exposure to toxins or radiation or whatever it is that causes us to get mutations as we get older. It's going to take you longer to knock out both of those copies just due to environmental exposure than if you were born with every cell in your body already lacking a functional copy. It's a slightly complicated concept, but I hope I got that across. I'm happy to go ahead with that and get in more detail later on if anyone wants to ask. So which syndromes affect the risk? Well, there are numerous very rare syndromes, but the main ones that certainly that I deal with are Lynch syndrome, which also used to be called a bit of a mouthful, HNPCC, or hereditary non-polyposis colorectal cancer syndrome, and hereditary breast and ovarian cancer syndrome, which is most commonly due to BRCA1 and BRCA2 gene mutations. There's also a bunch of other more recently discovered genes. I won't go into those in any great detail, but the point is, if you're found to have them, we can still offer you interventions that will hopefully help you over the longer term. So I'm going to touch briefly on Lynch syndrome, even though it's not something specific to the Ashkenazi population, because it's actually pretty common. The only reason that none of us have really heard of it, unless we're doctors working in the field, is they haven't had an Angelina Jolie yet with Lynch syndrome. The minute there's a celebrity with Lynch syndrome, I guarantee you all hear about it. But actually it's up to 1 in 360 people in the general population. Again, like all of these syndromes, it can be inherited from either side of the family. I don't need to go into the details of what these genes are specifically. They're basically stopping the cells behaving as they should do. And that's leading to a very high risk, up to 80% lifetime risk of bowel cancer, but also a very high risk of womb cancer, up to 60%, and up to a 12% risk of ovarian cancer for some of those mutations. There are also some other rarer cancers, kidney, bladder, stomach, small intestine, they're all listed there. These are relatively rare to begin with, and they're slightly commoner in people with Lynch syndrome, but the risks are not generally as high as they are for bowel, womb, and ovarian cancer. So why am I mentioning this? So that if you have got a family history of bowel and womb cancer, then you should talk to your doctor. It's nothing to do with Ashkenazi Jewish heritage. It's just actually quite common. 1 in 360 of us may have this. The control options for patients with this include taking aspirin, as I've mentioned, having regular bowel colonoscopies, which those of you over the age of 55 may have been offered every few years on the NHS anyway. If you've got Lynch syndrome, you get them every 18 months. You can't have your whole bowel removed, but someone like me can remove your womb tubes and ovaries to prevent you getting those kinds of cancer. You may be able to benefit from hormone treatment to try to prevent those cancers, but that's unproven. And although we do offer annual screening in terms of doing an ultrasound of the pelvis and a sample of the cells from the womb lining, this is as yet unproven in terms of its benefit. So now let's get on to what I think most of you are here to hear about more, which is hereditary breast and ovarian cancer syndrome. I can't harp on enough about the fact that this can come from either side of the family. It's so key to remember this. These are mutations in DNA repair genes, so you can imagine if you're not having functional genes that are capable of repairing your other DNA, then your whole DNA becomes more at risk, and that can eventually lead to cancer. There are these other genes listed below, which also can cause ovarian cancer and in some cases breast cancer as well. But getting back to BRCA, in the general population, it's only around 1 in 500 people that have one of these two genes mutated. So that's actually less common in the general public than Lynch syndrome. They confer a high risk of breast cancer, up to 80%, and it's often what's called the triple negative type, at least in BRCA1 mutation carriers. And that means it's a breast cancer that's not hormone sensitive. And so if there's even one member of a family who's developed that kind of breast cancer, depending on their age, that can be enough to get the NHS to test you to see if you've got a BRCA1 or 2 mutation. Then in terms of ovarian cancer, the risk varies according to which gene is mutated, and it's particularly a kind of ovarian cancer called high-grade serous ovarian cancer. Not serious, but serous without the I. It's the commonest kind of cancer in the general public. About 70% of ovarian cancers in the general public are high-grade serous, but in BRCA carriers, it's almost the only type that you ever see. There's also a slight increase, but nothing like as dramatic, in the risk of pancreatic and prostate cancer, and also male breast cancer as well. Male breast cancer is very rare, but it's slightly commoner in men with these mutations. Now, the key thing in the Jewish population is that it's a lot commoner. These are so-called founder mutations. There are 2 specific mutations in BRCA1 and 1 specific mutation in BRCA2 that tend to be found much more commonly in people of Jewish heritage. And that's for the obvious reason that people of Jewish heritage quite often will end up having children with other people of Jewish heritage. So that these genes tend to stay in the same families. They don't, or the same populations rather. And that's why there are also clusters in certain Polish and Icelandic communities as well. It's because people tend to end up getting together with and having kids with other like-minded people. It's the way the world works. And because these genes do not influence your ability to reproduce, at least not significantly, there are issues around BRCA and fertility, but nothing that really prevents people with BRCA having children in any major way. So these mutations carry on because they don't stop you having children. And that's what a so-called founder mutation is. So it's important to understand when the risk begins to increase, because this is what really affects women's decision-making around when they might want to have surgery to prevent cancer. And you can see on the left, BRCA1, the risks according to age for ovarian and breast cancer. On the horizontal axis is the age in decades, and on the vertical axis is your cumulative risk. That means the risk that you're going to get cancer. So 100% would be you're guaranteed to get cancer by that age, but 50% means by that age you've got a 1 in 2 chance of getting cancer. So I hope you can see my pointer. But for example, with ovarian cancer, with BRCA1, by the age of 50, you've got about a 15-odd%, bit under 15% risk of getting ovarian cancer. But that climbs to about 40% by the age of 70. Breast cancer risks are higher. But with BRCA2, the ovarian cancer risk starts at an older age, and in fact doesn't really begin to increase until you're nearly menopausal. So that means that women who want to have surgery to prevent ovarian cancer can delay their surgery until closer to the age of natural menopause, which is on average about 51. I wouldn't suggest they wait until they've been through the menopause, because sadly some of them do get cancer a little bit younger than that, so they're taking a risk. But it's not a huge risk, and it's a very personal choice. Women with BRCA1, however, their risk of ovarian cancer increases really from their late 30s onwards. So it's positively hazardous to delay ovarian cancer prevention surgery until they're 50, because some of them will sadly get cancer before then. There are a few things that can reduce the risk. There's pregnancy, so it's great if you've had kids, that will probably reduce your risk a bit, as does breastfeeding. Hormonal contraceptive use, contrary to what lots of people think, actually reduces the risk of ovarian cancer. And if you've had a sterilisation operation, that does as well. But sadly, none of these things are guaranteed to prevent ovarian cancer, so you can't rely on them to just go off into the sunset and not worry about your risk. Unfortunately, you do still have to worry about your risk. This does at least mean you can take heart from the fact you may have had children, you may have used the pill, and maybe that's done you some good and stopped you getting cancer so far. The risk reduction is really quite dramatic. This is from a major paper published in the New England Journal of Medicine, studying around 250 BRCA carriers who had risk-reducing surgery to remove their tubes and ovaries, and around 300 matched controls who didn't have the surgery, but they were BRCA carriers and they were the same age. They were followed up for 8 years. 2% of the women were diagnosed with ovarian cancer at the time of their surgery. That does sometimes happen, sadly, although we've got means of reducing that chance now. 1% subsequently developed a very rare kind of cancer. I won't go into that in detail now, but 1 in 5 of those who didn't have the risk-reducing surgery went on to get cancer over that 8.8-year follow-up. So that's a dramatic difference. You can see that risk-reducing surgery really does work and prevents women getting a cancer, which sadly is very often fatal. But of course, there are a number of downsides to doing this. There's the risks of just undergoing surgery. These are not high, and in fact, none of these women in this particular series from our own hospital had any major life-threatening complication. Infertility is an inevitable consequence of removing the tubes and ovaries. You have a premature menopause, which then gives you what we call vasomotor symptoms or hot flushes. Mood disturbance, so you may feel low in your mood, you may feel anxious, you may feel aggressive. There may be reduced sexual function. There will also potentially be an increased risk of heart attack and stroke. and also an increased risk of fractures due to osteoporosis. And now, more recently, we've realized there may also be, sadly, an increased risk of dementia. Now, it's very important to point out that hormone replacement therapy, or HRT, is very good at preventing these long-term issues. It's not so good at preventing mood disturbance and sexual function, but it is good, a bit better at this than this, maybe. Hot flushes, it's very good at preventing. It can't prevent infertility. So unless a woman has had a hormone-sensitive breast cancer, she is probably eligible to take HRT. And so these risks are not as great as you might think for most of the women I see. But there are some who aren't able to take HRT for whom this will be an issue. There are other things we can do to mitigate these risks. But even for those that are able to take HRT, the thing I always tell the patients is we can't guarantee you will feel the same in yourself once you've had the surgery and are on HRT as you feel now. Funnily enough, you might actually feel better. So if you've had very bad premenstrual syndrome or PMS, then going on HRT can sometimes cure that, but it's not a guarantee. And therefore, everyone considering this surgery has to go into it with really open minds and thinking, do I really want this surgery? I really want to prevent cancer, but I'm prepared to put up with these potential side effects, not knowing for certain whether they're going to happen or not. But I'm glad to say that overall there seems to be a psychological benefit for most women. This studied 850 BRCA carriers, 44% had surgery, the rest decided to have screening. So these are the ones that carry on with a risk of cancer. These ones have taken away their risk of cancer. And the surgery group, as you would expect, had significantly less cancer worries. But of course, they did have more hormonal symptoms, and sadly, they reported reduced sexual function. Now, this was from a time when people were much more hesitant about giving hormone replacement therapy. So I would hope that if this study was repeated now, the differences wouldn't be quite as big as they were in this study. But despite all of this, 86% would still choose surgery, and 63% would still recommend it to a friend with a similar problem. So I think this is very telling information, and it means that for most women, we are doing them a favour by offering them this treatment, as long as they're properly counselled about it and fully supported in their decision making. The other thing that's driving genetic testing now is for patients who've actually already got a cancer, because as I already mentioned, scientists have designed some really clever drugs which are active specifically in people with gene mutations such as BRCA1 and BRCA2. And so now if you're diagnosed with an ovarian cancer, unless it's a particular type, you are very likely to be offered a gene test, because it will actually help decide whether you can get one of these particular new treatments that could genuinely help you live longer. And then once that patient with cancer has been found to carry a BRCA mutation, then the NHS will automatically offer the testing to relatives who have not as yet had cancer to see if they may be a carrier, and therefore can be offered prevention strategies to stop other members of the family getting that same type of cancer or another kind of cancer, which is also due to that particular gene. So beginning to summarize now for you, if you've got a family history of ovarian only or breast only, or ovarian breast, or ovarian or breast and prostate or pancreatic, then you could have a BRCA mutation in your family. If you've got any combination of ovarian, womb, which is also known as endometrial cancer, and colorectal cancer, then you could have Lynch syndrome in your family. But it's really important to understand that those things are just a guide. They're not 100% reliable. And family history is frequently inaccurate, because often people don't really know what happened to your great-grandmother or your great-aunt or whatever. Not all families with an inherited mutation actually have any history of cancer. And recently there has been work done that shows that if you offer BRCA testing to all people of Ashkenazi heritage, irrespective of whether they have a family history of cancer or not, you could actually double the number of people who you find out have a mutation and then offer them a cancer prevention strategy. So how do you get your risk assessed properly? Well, the most important thing to do is to find out what kind of cancers your family members had and prove it. And you can do that relatively easily on the simple level of getting hold of a death certificate if that person is no longer alive. For people who are still alive, the cancer genetic services within the NHS can actually get hold of the information on the... Sorry, could someone mute their microphone, please? Sorry, someone's speaking. Sorry, could someone mute, please?
David Rez, please mute your microphone. If you're going to have a conversation, please don't be rude to our speaker. Thank you.
So the genetic services can actually get hold of cancer registry data on other relatives. If they're still alive, they have to get their permission to give that information out. But if they're deceased and you couldn't get their death certificate, for example, they can track that information down for you. So you explain the situation to your GP and ask if you should be referred to local NHS clinical genetic services. Now, if you feel your GP isn't particularly clued up about this, or you feel you're not getting the answers you want, there is an app you can use. There's an app for everything now, and there's an app for working out your family history as well. Now, this is designed to be used by healthcare professionals, but in all honesty, it's pretty easy to use. And if you're having trouble with it, I suggest you ask a colleague or friend, someone who's quite good at using apps to show you how. But what it basically does is it gets you to plug in your family history and tells you whether it might be that you should be referred to clinical genetics. But it's really important to note, and the app does take this into account, that you don't need anything like a stronger family history if you've got Ashkenazi Jewish heritage. So for example, if you're Jewish and there's any member of the family with ovarian cancer, that's pretty much enough to get you referred to the NHS. So this is what the app looks like on the App Store. And I would encourage you, if you're interested in this area and you've got a family history, to consider downloading it, give it a go. If you really can't navigate it, then do your best to get a friend or relative to help you. And if you're really stuck, then show it to your GP, because actually they will find it useful for all of their patients in this situation. And it's worth them spending a little bit of time getting used to using it, and they can practice on you, and then you've done them a favor and they've done you a favor. People often ask me, what about private gene testing? Well, I'm very much in favour of it, because sadly, the NHS is A, pretty slow to get around to offering people the tests, and B, because if you don't hit the threshold for NHS gene testing, you just can't get it. But that doesn't mean for certain there isn't a gene in the family. So if there isn't a strong family history, you can still, if you're interested, look and see if there's a bad gene in you personally. You can't get other members of the family tested. They would have to do it themselves. But if you're going to do this, you need to check the price and the quality first. You've got to check whether the private company is going to offer you the right information and counselling and clinical backup. You don't want to be told you've got a mutation and then that's it. We're leaving you in the lurch, you deal with it. You want to know that the company can offer you the right backup, because it would be dreadful to get that news and then be left floundering and then hoping the NHS can pick up the pieces. They will pick up the pieces, but it'll take them a long time to do that, and you'll get very stressed in the meantime. You should be aware of insurance implications. If you don't declare gene testing when you're taking out insurance policies, when they ask you to, your policies can be invalidated. At the moment, there's a moratorium which has been going on for, I think, over 15 years now, between the insurance companies and the government, which says they're not allowed to ask you for gene testing information if you're taking out policies less than £500,000. But these days, people will take out life insurance or mortgage insurance for more than that. So just be careful about that. Be aware that there's a possibility of getting an uncertain result, which might leave you feeling a little bit confused or uncertain, although I would argue before you've had the test, you're already uncertain, so it can't really get worse than that. And don't go into testing assuming you'll be negative. Most of you will be, statistically, but some of you will be positive. And if you haven't thought about what would you do if you were positive in advance of getting the test, then that result is going to be more distressing for you. And of course, remember, negative results don't guarantee you or your relatives won't get cancer. Cancer is really common. about 1 in 2 of us will get a cancer before we die, and about 1 in 3 of us will get it. Fortunately, for the vast majority of us, you don't get it till you're pretty old and you've had a good life. But for some people, if there are inherited mutations, they might get a cancer at a younger age. So finally, a couple of useful links. The Eve Appeal are the charity I work with the closest, and I'm glad to say that they've recently made me a trustee, and it's a real pleasure to be involved with them because they are such a good charity. They run a really tight ship. Every penny that goes into that charity gets spent on research or patient information, and I cannot bang the drum for them enough, and that's why I'm willing to become one of their trustees. Another website that's very useful is BRCA Umbrella, because this is for patients with BRCA. And you might be hearing something about that from the next speaker, I don't know. Anyway, I've rabbited on for far long enough, but I'm very happy to take questions. And I'll try and stop sharing the screen now so you can see me, if I can.
Thank you, Dr. Adam. Yes, please try and stop screen sharing. Let me see if I can do it from here. I can stop.
Yeah, I think that's at the bottom.
There we go. Great.
Okay, I'm going to start the ball rolling because I have a question and I have to ask it because I wrote it down. It was a bit complicated. Now, you were saying that after surgery, certain things come with an increased risk. Now, I can understand there being an increased risk after the surgery, particularly, you know, to remove ovaries and things. I can understand an increased risk of osteoporosis because you no longer have any estrogen, unless you have hormone replacement therapy.
Correct.
Ifs and buts and maybes about whether to have that. So I understand that. What I don't understand, and I'd really like an explanation if you're able, please, is why is there an increased cardiovascular risk after surgery?
So what we now know is that men have always had a worse cardiovascular risk profile than women. And what we now know is that women are protected by estrogen and are less likely to get blocked arteries. So when you lose your estrogen, your arteries begin to fur up. And for some women, that means they're going to be at an increased risk of heart disease and stroke in the long term, because if they've had a menopause at the age of 40 rather than 50, then they've just had an extra 10 years of furred up arteries. Men have never had protection, so they've got a lifetime of furred up arteries. Women are protected until they lose their estrogen, essentially.
Gosh, that's good to know. Thanks.
Yeah, no, but you're better off than I am, because you've had estrogen for 50 years probably, whereas I've never had it.
No, it's a bit worrying. I have to keep my cardiovascular.
You've got to keep fit.
Exactly.
Particularly in the postmenopausal years. Yeah.
Okay, I see Lindsay Kay has the question. Lindsay, unmute. Thank you.
Thank you, Dr. Adam. First of all, I just want to say thank you so much. That was so interesting. And also, I am 25 years post-surgery. So yes, I just wanted to let you know, if you use topical estrogen, you are fine. You actually are fine with cardiovascular. I am fine with everything. It just keeps you going, your bones, your blood pressure, everything. It just keeps you going fine. Yeah,
topical estrogens and where necessary progestogens are what we recommend these days, because there's not an increased risk of strokes, basically. And
I had
Can I just say though, if you've had a hormone sensitive breast cancer,
and you can't have it, unfortunately,
you can't use anything.
Yeah.
I had my mum had ovarian cancer. She was 36, and I had I was caught. Actually, it was caught when I was 41, and I had the surgery just in time, and I had everything, all my reproductive organs taken away when I was 41. So it's 25 years post-surgery. So I do recommend the surgery because it gives you a life.
Yeah.
Although there are things that you have to live with, but there is that. See, those are the options. If you have, I just didn't have an option. So there you are.
Yeah.
But the question I have, I wanted to ask if you My sister has got, I don't have children.
Can I just say, it sounds like someone's got their food mixer on.
I'm sorry, I'll shut the window. I live near,
Oh, look at you.
I live near the railway line. I've got the trains.
It's quiet now. Oh dear.
We don't want you to get too hot. It's a very hot evening.
No, exactly. The delights of Zoom.
The trains go up to Scotland. I'm sorry, they're fast.
Oh gosh. Well,
Yeah.
oh, I'm sorry. It's quite a lot of interference. Sorry, Lindsay.
The question I wanted to ask is that I don't have any children. My sister tested negative for the BRCA gene. She has her younger daughter has girls as well. What I want to know is if she was told just because she tested negative, I could test positive. It didn't necessarily mean, because it was definitely a familial situation. Would that definitely mean that because my sister was negative, that it is actually negative in the going through her line?
So if she's negative herself, she can't pass it on to her children.
So
but if she happened to have children with a man who was carrying it, then her children could still carry it. Okay. So it's a 1 in 2 chance if your parent has the gene, whether you get the good copy or the bad copy. So she got the negative, she didn't get it from her, presumably from your mum or dad. So she didn't have it. That means her kids are safe from her. But and it's unlikely, but if her partner happens to have it from his family, then the kids could still have it, but it's not very likely statistically.
Thank you very much. Thank you for that.
Another question. Someone who's called Lizzie's iPad. Mute. Thank you.
Yeah, Liz's iPad. Hello, I'm Liz. You actually partly answered my question because Lindsay asked the similar one. Thank you very much for a very, very interesting talk. I was diagnosed with ovarian cancer in July last year. I'm just looking at the doctor's letter, which says germline BRCA testing shows no clinically significant mutations. I'm on niraparib and hopefully doing well.
Great.
And my eldest daughter, who's finished with her family, is considering whether to have her ovaries removed anyway. Is this something that you would recommend? Or
so did you, sorry, I didn't quite hear, did you say that you did not have a inherited genetic mutation?
Yes.
So you've had a bad luck ovarian cancer rather than an inherited ovarian cancer, most probably.
Yes.
But what would happen normally is that someone would want to take a family history just to check what else is going on in your family. If there is just one first-degree relative with ovarian cancer, so your daughter has you as a first-degree relative and you've had ovarian cancer, but you do not have a gene mutation, at least not BRCA1 and BRCA2, then depending on the rest of the family history, it's not going to be standard practice to offer your daughter surgery because the risk would be under 1 in 20 of her getting ovarian cancer in her lifetime. Because you're BRCA negative, the good news is that means it's not likely she's inherited a very strong mutation from you. She might have inherited a bunch of very minor mutations, and the statistics tell us that her risk is probably only 1 in 20, assuming there is absolutely no other family history of cancer that could be of relevance. So her lifetime risk of ovarian cancer might be up to 1 in 20. That compares to the general population's risk of 1 in 50. So it's up a little bit, but it's not dramatically raised, and it's not raised to a level where we routinely offer the surgery to prevent it. We do, however, suggest that if she's not been on the pill and she's suitable to be on the pill, she could consider taking the pill as a preventive. If she has children and breastfeeds, great, that will reduce her risk.
No, sorry, she's 42, so she's
Okay.
finished with her family.
Okay, she's also probably too old for the combined pill then. But if she has had kids, if she has breastfed, if she has used the pill in the past, then her risk is probably less than 1 in 20 of getting an ovarian cancer. Now, we do occasionally offer surgery to that group of women if they're very, very stressed about it. But they have to understand they're taking a lot of a downside from the surgery if they're premenopausal. If they want to have it done postmenopausally, that's much less of an impact on their bodies and their long-term health.
Lovely. Thank you very much. I will pass that on to her.
Thank you. Deanne Gold. Unmute. Thank you.
Sorry, there's a bit of noise in the background. Can I just ask you, I know you touched on bowel cancer. So my dad died of bowel cancer when I was very young, and I had to have a colonoscopy. Well, they told me every 5 years, and now they've said it's only like every 10 years. But should I be, I've never actually thought about it, about my daughter being tested. Should I be sort of making sure that she gets tested for it or not?
So the way these things work is it's always best to test the person with cancer. So if your father's no longer with us,
no, it's not.
Sadly, that's not an option. How old was he when he got his bowel cancer?
He was about 48.
So that is very young. How
Yeah.
long ago did he pass away?
Oh, a long time ago now. It's like 36 years ago.
Okay, so sadly, it's very unlikely that they will be willing to, well, they're not going to find his tumour sample, not after 30, 40 years, because these days they actually get tumour samples and they do some basic testing that tells you if it's worth going on to the full gene testing. If that's your only family history of cancer, under current guidelines, I don't think you would be offered NHS gene testing.
My mum had ovarian cancer as well about 8 years ago.
Okay, so that's, because that's the other side of the family, that's not sort of linked.
Yeah.
But again, is your mother still alive?
Yes, she is, yeah.
So she should ask her oncologist if she can get BRCA tested. And then if she was positive, you would get that testing on the NHS. I don't think that you would get offered Lynch syndrome testing on the NHS. You could get it done privately and it would cost probably up to £500, maybe a little bit less. So it's not cheap.
Okay.
But there's a small possibility that you've got that, small. And if you want to know for sure, you could, I mean, you're already getting colonoscopies, but you'd be recommended to have aspirin as well. In fact, you should talk to your gastroenterologists about whether you should be on aspirin anyway, as a prevention. And you should also talk to them about, should you be having colonoscopies more frequently? Is there any way you can get Lynch syndrome testing? I'm not saying it's the right thing to do. I'm not an expert in bowel screening or bowel cancer risk assessment, but I don't think with that family history you would automatically get tested on the NHS, unfortunately. You should ask your gastroenterologist.
Okay, thank you. And thanks for the talk. It was very interesting.
Pleasure.
Our Rebitston Ali has a question.
Hi, Adam. Thanks for the talk.
Hi.
So, my mother had a very small breast cancer. It was actually just before we got married, so it was about 15 years ago, and she was, I think she was around 62. Fairly recently, over the last few years, and asked if I could get BRCA tested, and they said because she wasn't under the age of 50, you can't. And she's now since had multiple myeloma, which she's still fighting. And I'm just wondering if she should be entitled to get tested by her oncologist, and there shouldn't be any reason why BARTs can't do that, A, or whether, no, I should be able to get on the NHS.
So I think the melanoma is probably just bad luck. It's not thought to be linked to BRCA as far as I'm aware. If she had a triple negative breast cancer, so one that was not hormone sensitive, so if she didn't end up on a drug like tamoxifen, then she might be eligible for BRCA testing herself, and she should talk to her oncologist about that. Because she's over 50, I'm not sure that otherwise she would get NHS testing, but there's no harm in her asking her oncologist, pointing out her heritage if she's Ashkenazi. If she's triple negative, I'm pretty sure she would get offered it. If she wasn't a triple negative breast cancer, then she might be able to get it. I'm afraid I'm not certain because I don't work in the breast cancer area.
Any more
so the triple negative. Oh, the triple negative. Sorry, just to clarify, the triple negative means that it's not hormone sensitive.
Yeah, and also it lacks something called HER2,
right?
which is not a hormone thing. Yeah, so if it's not a hormone sensitive cancer and it doesn't have what's called HER2 as well, then that, which is what we call triple negative breast cancer, that increases the chance it's due to a mutation, and therefore the NHS is usually willing to test.
And if it is hormone sensitive, then they're less likely to
test. I think they're not very likely to, given the age she got it at. It's more of a sort of common or garden type breast cancer probably, and they're less likely to be willing to do it. But Ashkenazi BRCA testing only is cheaper than general public testing. If you just want to know about the 3 founder mutations, it's more like 250 quid. So it's a little bit more affordable.
So could I go myself, because the doctor said, because it was not unlikely, and you can just get that through like some sort of private clinics, and if so, are you able?
There are lots of different private setups, but if you Google private Ashkenazi Jewish gene testing, there's also a website called gynaecological.
Okay.
Gynaecological, which has stuff about that as well. And I'm not sure, but I think they might have been subsidizing Ashkenazi testing at some point. But they will certainly point you in the right direction. You don't want to pay over the odds for the general population one, because, I mean, it's possible that probably about 10% of inherited ovarian cancers in people of Jewish origin who have a BRCA mutation, it turns out to be a non-Jewish BRCA mutation. So it's not 100% guarantee that you're negative, but it's pretty likely that you're negative if you test negative for the Jewish mutations.
Lovely, thanks so much.
Okay.
Thank you. Do we have any more questions for Dr. Adam? Okay. Well, I'm going to say I sort of a thank you now, but we'll have a general one at the end. But thank you, it was really interesting, as were questions. And I think, you know, the talk really does encourage lots of questions and certainly lots of thought about this. And it just, you know, makes me think about my friend and interestingly, all the things you said. Her mother had breast cancer, she had breast cancer, her sisters had breast cancer, my friend had trouble with gallbladder, all sorts of weird and wonderful things, and is now has pancreatic cancer, as did her aunt.
Sorry, dreadful family history.
Yeah, absolutely dreadful.
Yeah.
And they're on all sorts of research programs now. And as my friend is terminal, she's trying to get all sorts of things done for her sister to make sure that she is screened so that she doesn't have to go through what my friend is going through. So, yeah. And I know another family where the daughter in her 30s had the operation, had all the surgery. Her mother died from breast cancer. I don't think that was the BRCA gene. Her father carried the BRCA gene, and he's now having treatment for prostate cancer. So it's, and I understand, I was told once that you get to look at, when you do exams, you get to look at prostate cancer and breast cancer under a microscope because they're very similar. You have to.
Oh, well, you've got to take me back to medical school 25 years ago. I'm not going to remember that, I'm afraid.
I was told that anyway. But thank you so much. Really interesting. And I think you've certainly given us a lot of food for thought, and also to consider, you know, those of us who need to, where we might go. You've given us the signpost. So thank you very much.
It's a pleasure.
So you're getting a silent round of applause. I can see. So thank you very much, Dr. Adam.